You know the scene. We've all seen it 1,000 times. It's practically baked into our cultural DNA at this point. You're watching a movie or maybe one of those high-stakes medical dramas. Grey's Anatomy, ER, take your pick. The camera zooms in real tight on the monitor in the hospital room, and it's beeping rhythmically, beep, 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 beep. The tension is just palpable. And then all of a sudden, you get that sound, that high-pitched, continuous tone, the flat line.
The universal sound of the end.
Exactly. And the doctor, he looks at the monitor, maybe checks his watch, shakes his head all solemnly, and then just pulls a sheet up over the patient's face. Fade to black.
Scene over. Credits roll. It's clean. It's instantaneous.
And incredibly dramatic.
It's very dramatic. It is also, for the most part, completely and utterly misleading.
And that is exactly what we are here to talk about today. Because if there's one thing we've learned doing these deep dives, it's that reality is rarely as simple or as fade to black as Hollywood makes it seem.
Not at all.
In the real world, when that heart stops, the story isn't over. In fact, for the medical team, a whole new story is just beginning. A highly choreographed, strictly regulated, and deeply human one.
That's right. The moment a patient's heart stops, a very complex clock starts ticking. You're shifting gears entirely from the frenetic, chaotic energy of trying to save a life, what we call a code blue,
Right.
to the very precise, very careful management of a death.
So welcome to what I'm affectionately calling the funeral channel edition of the deep dive.
I think that fits perfectly. It's the side of the hospital no one really wants to talk about until they're forced to. It's the hidden manual.
Today, we are opening that black box. We're looking inside the hospital room after the flatline. We've pulled, a massive stack of material, hospital handbooks, resident survival guides, legal protocols, nursing last offices manuals.
Even some really fascinating bioethics papers.
And we are going to walk through the medical, the legal, and the emotional protocols that govern that first hour after death.
And I think for a lot of listeners, this might sound a bit morbid at first glance.
A little bit, yeah.
Why do we need to know the checklist for a dead body?
Yeah.
But when you actually read these protocols, the checklists, the warnings, the very specific physical actions, you realize this isn't just bureaucracy. It's a safety net. It's how we ensure dignity when the person can no longer demand it for themselves.
That is the mission today.
Yeah.
To understand that shift from clinician to, well, almost to a guide. We're going to talk about everything from the Lazarus phenomenon, which is as wild and terrifying as it sounds.
Oh, it is.
To the legal pitfalls of a death certificate that can mess up like national funding, all the way to these quiet rituals that are happening in hallways right now that most of us don't even know exist.
It's a fascinating territory. It's where biology meets the law and where rigid procedure meets profound grief.
So let's start right at that moment of truth, the pronouncement. In my head, pronouncing someone dead is just the doctor saying, okay, they're gone. But looking at these resident handbooks you've shared, it's a formal medical act. It's not just an observation.
No, absolutely not. And this is a crucial distinction. A machine, that monitor we talked about, it can suggest that life has stopped. It can show a flat line, which we technically call a systole.
A systole, right.
But a machine cannot diagnose death. Only a human clinician can do that. It is a clinical judgment.
So you can't just trust the beep. You can't just look at the line and walk away.
You cannot. Think about it.
Yeah.
Machines malfunction. Leads fall off the chest because of sweat or, movement during CPR. Batteries die. The game on the monitor might be turned down too low, making a small heartbeat look completely flat.
Okay, I never even thought about that.
The protocol requires a physician to verify the irreversible cessation of 3 specific things: circulatory function, respiratory function, and neurological function. And there is a specific choreography to doing this so that you don't make a mistake.
A mistake here seems, catastrophic. Declaring someone dead when they aren't, that's literally the stuff of nightmares.
It is the ultimate error. It is the error you cannot walk back from, which is why the very first step in the protocol, before you even touch the patient to check for a pulse, is something that seems incredibly mundane, but is foundational.
What's up?
You check the ID tag.
Really? That's step 1. In the middle of all that emotion with a body in front of you.
Step 1. Every single time. Imagine the administrative and ethical horror of pronouncing the wrong patient dead in a shared room or mixing up charts. It happens.
Wow.
In a trauma situation, you might have John Doe or unknown patients. You have to physically verify the identity on the wristband against the chart. It grounds the doctor. It reminds them, I am pronouncing this specific person. Once that is done, Only then do you move to the physical exam.
And this is where the 60-second rule comes in, which I saw in the survival tips for residents source we have. This isn't just a quick check the neck like you see on TV.
No, that is pure fiction. They touch the neck for 2 seconds and shake their head.
Yeah.
In reality, you must listen for heart sounds auscultation with a stethoscope and feel for a carotid pulse in the neck for a minimum of 60 seconds.
60 seconds. A full minute. That feels like a lifetime when you're standing in a silent room with a grieving family watching you.
It feels like an eternity. You are standing there, head bowed, just focused. But you have to do it for the full minute because of things like extreme bradycardia, a very, very slow heart rate, or something called agonal rhythms.
Okay, define that for us. What's an agonal rhythm?
An agonal rhythm is, well, it's a dying heart rhythm. It can be incredibly slow, irregular, very, very weak. If you only listen for 5 seconds, you might catch the silence between 2 very slow beats and just assume the heart has stopped.
But it hasn't.
But 10 seconds later, there might be another thump.
Yeah.
So you haven't confirmed death. You've just confirmed a pause. At the same time, you're also watching for spontaneous respiration for 30 to 60 seconds. You are ruling out apnea, where the breathing might stop and then start again.
And that's different from agonal breathing, right? The kind of fish out of water look.
Exactly. That's a brainstem reflex. The patient isn't getting oxygen, but the brainstem is firing this panic signal to the diaphragm to gasp. It can look very much like life. It can look like a struggle. So the doctor has to differentiate between a reflex gasp and a sustainable breath. You have to be absolutely sure that the silence you are hearing is permanent.
Okay. And then you have the neurological check. The classic light in the eyes.
Right, fixed and dilated pupils with no reflex to light. When the brainstem dies, the pupils just blow wide open and stop responding. But there's another part of the neurological check that the protocols are very, very specific about, and it actually highlights how the doctor's role is changing in that moment.
What's that?
To prove someone is unresponsive, you have to administer a stimulus. Pain, essentially.
Right, to check for a reaction. If I pinch you, you pull away. It's an instinct.
Correct. But if you look at the language in the hospital handbook source, it explicitly forbids overtly painful stimuli. Things like nipple twisting or deep sternal pressure, especially when the family is present.
Yeah, I read that and I just froze. The text actually says nipple twisting is inappropriate. It's so jarring to see that written down in a medical text. But I guess in a trauma bay, when you're trying to wake someone up, you do whatever works.
You do. When you are trying to save a life, a sternal rub grinding your knuckles into the chest bone, it is a necessary violence. It hurts. It is designed to hurt, to assess their level of consciousness. You are trying to provoke a response to save them.
But now you're not saving them.
Exactly. The moment you are pivoting to pronouncing death, that action changes meaning completely. It goes from a diagnostic tool to, frankly, an assault on a body that deserves dignity.
It changes from rescue to respect.
Precisely. The protocol suggests using a discrete pressure on a nail bed instead. It's subtle. You can do it while you're holding their hand. To the family, it just looks like a gesture of comfort. But it provides the clinician the data they need. Is there any withdrawal reflex?
That's a perfect example of that shift. It's precision, but with respect. Now, we have to talk about the thing in the notes that, it just stopped me in my tracks. The Lazarus phenomenon.
Yes. This is the thing that keeps doctors up at night.
The name alone, Lazarus, back from the dead. This isn't a ghost story. This isn't like hospital folklore. This is a real medical thing.
It's very real, although thankfully it's rare. Yeah. The technical name is autoresuscitation, and it refers to the spontaneous return of circulation, the heart literally starting again after CPR has been stopped and the patient has been declared dead.
Wait, how is that physically possible? If you've stopped CPR, you've basically admitted the heart isn't working on its own. How does it just kickstart itself without anyone touching it?
The leading theory is something called dynamic hyperinflation. Now, think about CPR. You're aggressively pumping the chest, and usually you're forcing air into the lungs with a bag valve mask. You're squeezing air in.
Wow.
You're creating a huge amount of positive pressure inside the chest cavity.
Okay, so you're pressurizing the system, like blowing up a tire too full.
Exactly. And that high pressure in the chest can actually prevent blood from returning to the heart. The veins just can't push blood into that high pressure zone. It's like squeezing a balloon so hard that nothing can get in.
I see.
But the moment you stop CPR, the moment the team steps back, that pressure drops. The air that was trapped in the lungs escapes.
The pressure releases.
Right. And suddenly all that venous blood can flow back into the heart because the resistance is gone. And that rush of volume, that sudden filling of the heart chambers, might be just enough to stretch the heart muscle and trigger the electrical system one last time.
So the act of stopping the rescue attempt is what actually allows the heart to beat again.
In these very rare cases, yes. The irony is just profound. The rescue breathing was actually inhibiting the circulation.
So how often does this happen?
The data we have suggests it happens in about 6 out of every 1,000 cases where CPR fails. And here's the really scary part. It usually happens between 3 and 10 minutes after all efforts have ceased.
3 to 10 minutes. So let's play this out. The team stops. They call the time of death. They go out and they tell the family, "I'm so sorry." The family comes in to say goodbye, and the patient gasps. Or their pulse comes back.
It's a horrifically traumatic event for the family. You've just told them their loved one is dead, and now they see signs of life. It gives them this terrible false hope, often only for the patient to die again minutes or hours later.
And for the doctors, the liability.
It's a massive liability and a huge psychological burden for the medical team. And that's why the protocol we have here includes a very specific safeguard. He recommends waiting and monitoring for at least 10 minutes after stopping CPR before you officially pronounce death.
The 10-minute buffer.
Precisely. You stop, you wait, you watch. You ensure that the biology has truly settled before you make that legal pronouncement. It prevents the trauma of reanimation after the bad news has already been delivered.
That explains why in some of these accounts we read, the doctors don't just rush out of the room. They kind of hover. They're double-checking.
They are. They're respecting the physiology of that transition. They're making sure the door is truly closed before they tell you it's closed. They're guarding against the Lazarus effect.
Okay, so the physical exam is done. The ID is checked. No pulse, no breath, no Lazarus effect. Now comes what has to be the hardest part for the human being wearing that white coat. The pivot. You have to turn around and talk to the family.
This is the moment where the doctor stops being a technician and starts being a human guide. And the sources we have, specifically these notification guidelines for residents, are fascinating because they script this interaction almost as rigidly as the medical check.
It mentions something called the warning shot, which sounds aggressive, but I'm assuming it's not.
No, it's not aggressive. It's a cognitive psychological tool. You cannot just walk into a room and say, "He's dead." The human brain, especially when it's under stress, it just filters. If you deliver catastrophic news instantly, the brain will often just reject the information. It creates a barrier of denial. It literally bounces off.
So the warning shot prepares the brain.
Exactly. It's a phrase like, "I'm afraid I have some very bad news." It forces the listener's brain to pause and prepare itself for a blow. It triggers a state of alertness. It sounds so simple, but it is absolutely crucial. If you don't do it, the family might not even hear the next sentence. They might just hear a buzzing sound.
And then there's the language itself. The guidelines are extremely strict about avoiding euphemisms.
Oh, this is one of the hardest things for young residents to learn. We're all socially conditioned to be soft. We want to soften the blow. So we say, "Passed away, we lost him, he didn't make it, he's gone to a better place."
We lost him. Always sounds so strange to me. Like you misplaced him, like he's just wandering around the basement somewhere. Have you checked the cafeteria?
Exactly. And in a high-stress trauma situation, families have literally interpreted it that way. They've said, "Well, find him," or "Where did he go?" Denial is a powerful drug. If you leave even a tiny crack in the door, people will run right through it.
So you have to be blunt.
The protocol demands absolute clarity. You must use the words "died" or "dead."
He has died.
It sounds harsh to our ears, but it's the only way to ensure understanding. There is absolutely no room for ambiguity when you are changing a family's life forever. You have to be the anchor of reality in that room.
The source also mentioned something called the 3 points rule. What's that about?
When a person receives news like this, their cognitive processing speed just drops to near zero. They are in shock. They will not remember a 10-minute explanation of the pathophysiology of the cardiac arrest or the patient's potassium levels.
Right, they're not taking notes.
No. So the rule is, stick to 3 brief points. Keep it simple.
Can you give an example?
He had a severe heart attack. We tried to restart his heart for 30 minutes. Unfortunately, he has died. That's it. That's all they can process. Anything more will just wash right over them. You can answer questions later, but the initial delivery has to be digestible.
And there's a section here on managing the room. It almost feels like stage direction. Never in a hallway. Everyone must be seated.
That's about control and safety. If someone faints, which happens frequently when hearing news of a sudden death, you want them in a chair, not standing on a hard terrazzo floor.
That makes sense.
And sitting down signals that you are not in a rush. If the doctor stands while the family sits, it's a power dynamic. It feels like a lecture. It feels like, I have to leave. If everyone sits down together, it's a conversation. It says, I am here with you in this.
I found this survival tips for residents section really, I don't know, touching. It acknowledges that these residents, who are often in their mid-20s, feel totally inadequate doing this. They're barely adults themselves, and they have to go tell a wife of 50 years that her husband is gone.
They do. And they often feel like they failed. They went into medicine to cure people, and death feels like the enemy winning. The advice in these guides is really profound. One tip is, don't overpersonalize. Don't ever say, I know what you're going through, because you don't. You really, really don't.
And the other big one is, it's okay to be silent.
Silence is so hard for us. We want to fill the air. We want to say something, anything, to make it better.
It's awkward. We feel like if we're talking, we're fixing it.
It is awkward. But in this context, being there is the intervention. Just witnessing their grief without trying to fix it, because you can't fix it, is the most professional and human thing you can do. Just sitting there while they cry, handing them the tissue. That is the therapy. It's that quiet human care amidst all the medical steps.
So the family has been notified. The doctor steps back. Now, the room changes hands again. This is where we get into the last offices. This is the nursing domain, right?
Correct. Last offices is a traditional term for the final care of the body. This is where we move from diagnosis and communication to dignity and preparation. And again, the details in the nursing protocols are incredibly specific and thoughtful.
Let's talk about positioning. The sources mention laying the patient flat, supine. But there's this very specific instruction about placing one pillow under the head. Why one? Why not make them comfortable with two? Or none at all?
Well, it's not about comfort anymore. The patient can't feel. It's about appearance for the family when they come in to view the body. If the head is too low with no pillow, gravity takes over. Blood starts to pool in the face, a condition called livor mortis.
What does that look like?
It causes a deep purple or blue discoloration and some swelling. It can look like bruising, like they've been in a fight. It looks traumatic.
Oh, that would be terrifying for a family to see. You walk in and they look hurt.
Exactly. But if the head is too high, say with 2 or 3 pillows, the chin tucks into the chest. As rigor mortis sets in, the stiffening of the muscles, the body can lock in that position. It just looks unnatural and uncomfortable.
So one pillow is the sweet spot.
One pillow is the physiological sweet spot. It keeps the fluids draining away from the face and keeps the neck in a neutral, restful position. The goal is to make the face look as much like the person they knew as possible.
That is such a tiny detail, one pillow versus two, but had a huge impact on the final memory the family has. And then what about the eyes and mouth? The source says, light pressure on the eyes for 30 seconds.
Right. Immediately after death, all the muscles are flaccid. So the eyes tend to slide open, the jaw tends to drop. It's that slack-jawed look. The nurses will gently place a rolled towel under the chin to keep the mouth closed. And they'll close the eyes and just hold them for a bit. It's all about creating a memory image that is peaceful. You want the family to sleep, not death.
There is a critical distinction here, though, between a natural death and a medical examiner case. If it's a natural death, the nurses remove all the tubes, the IVs, the catheters, they wash the body. But if it's an ME case...
You stop. You touch nothing.
Everything stays. Even the tube down the throat, the needles...
Everything. The endotracheal tube, the IV lines, the Foley catheter, the EKG pads on the chest. If the death is accidental, suspicious, or in any way unexplained, the body is evidence. It is effectively a crime scene. The lines and tubes on the body tell the story of the resuscitation attempt. If you pull them out, you are altering the scene of an investigation.
That must be so hard for the nurses.
It is incredibly hard. Their instinct is to clean the patient up, to make them presentable and dignified for the family. They want to show care, but legally, they cannot. And then they have to explain to the family why their loved one still has a tube in their mouth. It requires a lot of gentle education.
Let's talk about the wedding ring rule. This one feels really high stakes.
It is. Personal property is a huge source of anxiety and potential litigation for hospitals. Things get lost. But the wedding ring is special. Often, families want the deceased to be buried or cremated with it on. But rings can easily slip off a cooling body.
Why is that?
As the body cools, a process called algor mortis, the tissues shrink slightly. The skin loses its turgor, its elasticity. So a ring that was snug on a living, warm finger can become very loose on a cold one.
Oh, wow. I had not thought of that at all.
So the protocol is to secure the ring. You don't just leave it. You use gauze and tape, and you literally tape it to the finger so it doesn't get lost in the body bag or during transport to the morgue. It ensures that the ring stays with the patient until the funeral home takes custody.
This section on the body also really highlights how the hospital, which we think of as this secular scientific machine, has to suddenly bend to accommodate religion and culture. The last offices aren't one size fits all.
No, and a good hospital system has this built right into their handbook. It's not just nice to have, it's essential for respectful care. For instance, take the Jewish and Muslim protocols. Both faiths emphasize rapid burial, often within 24 hours.
That is a very fast turnaround.
It is, and both generally discourage autopsies because they view it as a desecration of the body. And for a Jewish family, there's the concept of shemira, or watching over the body, so it shouldn't be left alone.
So the medical team has to speed up the paperwork.
Exactly.
Yeah.
The administrative engine has to rev up immediately. You can't let a body sit in the morgue over the weekend if the family needs a burial by sundown the next day. The doctors need to know this right away to prioritize the death certificate.
Then you have the Buddhist perspective, which is almost the opposite regarding the timeline.
It is. Some Buddhist traditions believe the spirit is still transitioning after the breath stops, that the consciousness is withdrawing from the body. Touching or moving the body too soon, especially any cold or rough handling, can disturb that process.
So what's the protocol?
The protocol suggests leaving the body untouched for 3 to 8 hours, if at all possible.
That is a big ask in a busy hospital where they need that bed for the next patient.
It's a huge ask. But that's where the art of medicine comes in. Negotiating that time, finding a private room, finding a way to respect that belief within the very real constraints of the institution.
And what about the Sikh 5Ks?
These are specific articles of faith, like the kara, which is a steel bangle, or the kigunga, a wooden comb, or the kachera, a type of undergarment. To an outsider, they might just look like jewelry or clothes that should be removed.
But they're not.
They're not. The protocol warns staff explicitly, do not remove these. They are part of the person's religious identity. Removing them would be a profound violation.
And for Hindu families, I read that the family themselves might want to wash the body.
Yes. In that case, the nursing staff steps back completely. They provide the water, the towels, the privacy, and they let the family perform that final act of service. It's a beautiful subversion of the usual sterile hospital environment. It turns the hospital room into a sacred space, just for a moment.
It really is. It allows the family to reclaim their loved one from the medical system. But unfortunately, we have to live the sacred space and enter the office. Segment 4, the administrative labyrinth. The paperwork of death.
It sounds dry, I know, but this is where the reality of death gets codified for the state. And it is surprisingly complex.
Okay, let's start with the time of death. I always assume time of death is the exact second the heart stops beating, but you're saying that's not what goes on the paper.
Rarely. Imagine the doctors doing that 60-second pulse check we talked about. Let's say the heart stopped at 10:00 a.m. on the dot. The doctor listens until 10:01. Then they check the pupils. Then they check for a pain response. Then they look at the clock on the wall. It's now 10:05.
So what time goes on the chart? 10:00 or 10:0?
10:05. The time of death recorded on the certificate is the time the physician completes the assessment and announces it. It's the time the death was pronounced, not necessarily the exact moment the biology ceased. It's a legal definition, not a biological one.
That's a fascinating nuance. So you could technically be dead for 5 minutes before you are legally dead?
Exactly. And then we get to the death certificate itself, the Electronic Death Registration System, or EDRS.
The EDRS. The bane of many a doctor's existence, I hear, but crucial for public health. I was reading about the logic of the cause of death section. It's almost like a logic puzzle. There's a part 1 and part 2, and apparently doctors get this wrong all the time.
They do. The single most common mistake is listing the mechanism of death as the cause of death.
Give me an example. What's the difference?
Okay, so a doctor might write cardiac arrest as the cause of death, but cardiac arrest just means the heart stopped. Everyone who dies has cardiac arrest. It's the final common pathway. It's like saying the cause of death was death. It tells us absolutely nothing.
So what does the state want to know?
The state doesn't want to know that the heart stopped. They want to know what stopped it.
So what should they write instead?
They need to follow the chain of events. So line A is the immediate cause. Let's say exsanguination, bleeding out. Okay, why? Line B, due to a gunshot wound to the chest. Line C, due to assault. You have to tell the story backwards, from the death to the root cause.
And how would that work for a disease?
Same logic. Line A, acute myocardial infarction, a heart attack. Line B, due to coronary artery disease. Line C, Due to hyperlipidemia, which is high cholesterol and smoking, you are tracing the narrative of the disease process.
And part 2 is for things that didn't directly kill them, but helped it along.
Contributed, exactly, contributing factors. Let's say the patient had that heart attack, but they also had severe COPD, which is a lung disease. The COPD didn't cause the heart attack, but it made their oxygen levels lower and their body too weak to survive the stress of it. That goes in part 2.
This data actually matters, right? It's not just for the family's records.
Oh, it is vital. It determines national funding, research priorities, public health policy. If every doctor just writes cardiac arrest, we have no idea what diseases are actually killing the population. Are cancer rates up? Is heart disease down? Is there a new epidemic on the horizon? Accuracy here is a public service.
Then there's the big, scary authority figure, the medical examiner, or the ME, or in some places, the coroner. The doctor can't just sign off on every death certificate. Sometimes they have to call the ME.
That's right. You can think of it this way. The doctor has jurisdiction over natural deaths. The medical examiner has jurisdiction over pretty much everything else. They are the police of death.
So what triggers an ME call?
The list is very specific, obviously homicides and suicides, but also accidents. And this is one that surprises people. Even if an elderly woman falls, breaks her hip, gets surgery, and then dies of pneumonia 2 weeks later, that is legally an accidental death.
Wait, really? Even 2 weeks later?
Yes. The fall started the chain of events. If she hadn't fallen, she wouldn't have broken her hip. If she hadn't broken her hip, she wouldn't have been bedridden. If she wasn't bedridden, she likely wouldn't have developed pneumonia. The fall is the proximate cause. The ME needs to know.
What about the 24-hour rule I've heard about?
If a patient dies within 24 hours of being admitted to the hospital, it is automatically reportable in most jurisdictions.
And why is that?
It's a safeguard. And to rule out any potential medical malpractice or negligence, and also to ensure there isn't a public health threat that the hospital missed. Maybe they have meningitis and it's contagious. Maybe the hospital administered the wrong drug. It's a check on the system. Another trigger is unattended deaths, if the patient hasn't seen a doctor in, say, 20 or 30 days.
And the ME has, for lack of a better term, superpowers.
They do. They can seize the body. They can order an autopsy without family consent.
Even if the family says no. Even if it violates their religion.
Yes. If the law requires an investigation, say for a murder trial or a workplace accident or a potential plague, the family's wishes are overridden by the state's need for the truth. The state has a compelling interest in knowing why its citizens are dying.
That's a heavy realization for a family who just wants to plan a funeral.
It's often a point of major conflict, but the doctor's role is to bridge that gap, to explain that this isn't the hospital being difficult. This is the law protecting the community.
Moving on to segment 5. There's another group that has a kind of jurisdiction in this moment, the Organ Procurement Organization, or OPO.
This is a critical part of the protocol, and it's one of the most misunderstood. People have all these fears about organ donation.
The myth.
The myth that, oh, the doctor won't work as hard to save me because they want my kidneys.
Exactly. I think a lot of people have that thought in the back of their minds.
And to combat that, the system is designed with a strict firewall. The team treating the patient, the team trying to save their life, is not allowed to have anything to do with the organ donation people. Nothing. They are different teams, different employers, often in different buildings.
In fact, the doctor treating the patient isn't even allowed to bring up donation with the family in many cases, right?
That's correct. The doctor treats. If the patient dies or is clearly dying, federal law mandates that the hospital must report that death to the OPO. The OPO then looks at the chart remotely. They are the ones who decide if the patient is a potential candidate. If they are, the OPO sends their own trained requester to talk to the family.
So the doctor calls the death, and then this completely separate team comes in.
Essentially, yes.
Yes.
It ensures that the request comes from a specialist who is not part of the grieving process from the failed resuscitation. And there are two main pathways here that are important to distinguish. There's donation after brain death, or DBD, and donation after cardiac death, DCD.
Okay, break those down for us.
DBD brain death is when the brain has permanently and irreversibly stopped functioning. The person is legally dead, but the machines are keeping the heart beating and the lungs inflating.
So the body is still warm. The color is good.
Right. The organs are being perfused with oxygenated blood. This is the ideal scenario for transplant because the organs are in perfect condition. The patient is dead, but the biological machinery is maintained until the surgery to recover the organs.
And DCD, cardiac death.
This is a situation where the patient has a non-survivable injury, say a massive stroke or a high spinal cord injury, but they are not brain dead. They still have some brainstem function. But the family has decided we don't want to keep them on machines forever. They decide to withdraw life support.
So what happens then? They take the patient to the OR?
They take them to the operating room or a suite right next to it. They remove the breathing tube, and then they wait.
They wait for the heart to stop naturally.
Yes. And this goes right back to that wait time we talked about earlier. Once the heart stops, the doctor has to wait that mandated 2 to 5 minute period to ensure there's no auto-resuscitation. Only then can they pronounce death.
And the surgical team is just waiting there.
They're scrubbed in, they're standing by, ready,
Okay.
because the moment the 5-minute timer dings and death is pronounced, the clock starts for the organs. They have to rush in, clamp the major vessels, and flush the organs with a cold preservative solution. It's a frantic race against time because the organs start dying the moment the circulation stops. It's called warm ischemia time.
That is incredibly intense to even think about.
It's very high pressure. But even if organs aren't viable, maybe the patient was too old or the heart took too long to stop, there is still tissue donation. Corneas, skin, bone, heart valves. These can often be recovered up to 24 hours after death. So the OPO is interested in almost every death, just in case.
This brings us to our final segment, and honestly, it was the most moving part of this research for me. We've talked about checklists and laws and biology and paperwork. But how does the staff survive this? How do they process the fact that they just managed a death?
For a long time, the answer was they didn't. They just compartmentalized. They shoved it down and moved on to the next patient. Burnout and vicarious trauma were just accepted as the cost of doing business. But recently, there's been a movement to integrate rituals into the workflow, rituals of resilience.
The first one is called the medical pause, and it was started by a nurse, Jonathan Bartels.
Yes, it's a beautiful, simple concept. Imagine a trauma bay. It's chaotic. It's noisy. There's CPR. People are shouting. You might hear ribs cracking. Then time of death is called. The energy just crashes. Usually everyone just rips off their gloves and walks away to go chart. It feels empty and abrupt.
Disjointed.
Bartels suggested stop, just for 45 to 60 seconds.
What do they do in that minute?
They stand around the bed. The team leader says something like, let us take a moment to honor this patient, who was someone's child, maybe someone's parent, and to honor the efforts of this team. And then they just stand in silence.
Just a minute of silence.
It does two incredibly important things. First, it gives dignity to the deceased. They aren't just a failed case. They are a person. And second, it allows the staff to doff the emotional weight. It puts a period at the end of the sentence. It acknowledges, we tried. It's over. We are human.
The stats on this are pretty impressive. I saw that 79% of staff say it brings them a sense of closure. It helps them go to the next room and be fully present for the next living patient.
It resets the nervous system. It acknowledges the humanity that was just in that room. And then for organ donors, there's the honor walk.
I've seen videos of this online. It destroys me every single time.
It is one of the most powerful things you can witness in a hospital. When a donor is being wheeled from the ICU to the operating room for that final time, the hospital staff lines the hallways. Doctors, nurses, janitors, administrative staff, everyone. They stand silently against the walls as the bed passes by.
It's like a military salute or a state funeral.
It is, and it reframes the tragedy. For the family walking behind that bed, their loved one isn't just a victim of a car crash anymore. They are a hero. They are about to save 3, 4, maybe 5 lives. And for the staff, it's a physical manifestation of respect. It turns a clinical transport into a sacred procession.
It really seems like we're getting better at this, at realizing that death isn't just a biological failure, but a social and emotional event that needs structure and ritual.
I think we are. We're realizing that the protocol of death isn't just red tape. It's the scaffolding that holds everyone up when their world is falling apart. It holds the family, it holds the staff, and in a way, it holds the patient.
So let's synthesize all this. We started with the movie Flatline, the simple beep and fade to black. We've ended up in a hallway full of silent nurses honoring an organ donor, a doctor carefully checking a nail bed for a pain reflex, and a clerk meticulously typing a cause of death code into a computer.
The takeaway for me, I think, is that accuracy and dignity are really two sides of the same coin. Checking the ID tag is about dignity. Waiting 10 minutes for the Lazarus effect is about dignity. Filling out the death certificate correctly so we can understand public health is, in a way, also about dignity on a larger scale.
It's protecting the narrative of that person's life and their death.
Precisely. It's ensuring that the end of their story is handled with the same care and precision as we hope the beginning was.
Here is my final thought for you, the listener. Something to chew on after you take your earbuds out. We spend decades planning for life events. We plan weddings, we plan for births, we plan retirements, we have checklists for vacations, but we almost never look at the specific minutes that mark our end.
It's the one milestone we all share, yet it's the one we consistently look away from.
But hearing all this, knowing that there is a script, knowing that when that moment comes for us or someone we love, there's a safety net of protocols. From the single pillow under the head to the warning shot to the moment of silence, it actually makes the concept of mortality feel a little less frightening. You aren't just falling into a void, you are being caught by a system designed to care for you one last time.
It's a comforting thought.
Mm.
You are not abandoned in that moment. You are managed with respect.
And on that note, we will wrap up this edition of The Deep Dive. Thanks for stepping into the funeral channel with us.
It was a privilege.
Stay curious, and we'll see you on the next one.